Great question, Rob. I think a number of factors go into stratifying newly diagnosed ATTR CM patients. Probably the most important thing that I look at is the functional status. How well are they doing? Are they able to do activities of daily living? What kind of limitations do they have? And so that can be formally categorized in things like New York Heart Association class, but also just kind of getting a general clinical sense of how well they're able to perform exercise and other daily functions. And there have been a number of staging systems that have been developed over the years. Probably the most commonly used would be the National Amyloid Center staging system, or the NAC staging system. And that incorporates NT-proBNP as well as EGFR into those parameters. So patients who have a higher NT-proBNP, that cardiac biomarker, and have worse renal function tend to have a worse prognosis. So, I think that those pieces of information can be helpful as well. Yeah, so, I think that a practical thing that's helpful is to understand the status of heart failure. And there's been nice work done looking at oral diuretic intensification. And think that's a very tangible biomarker to follow. If a patient needs a higher dose of oral diuretics in order to maintain euvolemia, often a sign that their heart failure is progressing. So that's something that can be assessed in these, longitudinal visits. Certainly, if their NT-proBNP is going up, their renal function is worsening, those are important pieces of information as well. And then again, looking at their functional status. I often ask patients when I see them in clinic, how do they feel in terms of what they could do compared to, say, maybe 6 months ago or 12 months ago. And patients usually can recall pretty well, how their current functional status compares to earlier time point. I would say there's not any specific laboratory trends that are predictive for rapid disease progression. From a clinical standpoint, those patients who've had recurrent heart failure hospitalizations, I find that to be a very strong predictor of poor prognosis. And then also those that are difficult to manage with diuretics. So those that have a widely fluctuating diuretic use is also a concerning sign. I think as we've learned or trying to learn the role of biomarkers in measuring disease progression, ATTR, I often will incorporate them into routine lab checks. So patients who are on diuretics and some of the other heart failure medications, I'll routinely monitor renal function and electrolytes. And so if I'm checking those labs from a clinical standpoint, I'll usually add on biomarkers such as NT-proBNP and troponin. And in terms of how that influences treatment decisions, I think it's another piece of information that I combine with the patient's functional status, their preference for therapies, have they had recent hospitalizations? And so if there's an overall trend of signs of clinical worsening based on their presentation, as well as some of the information I get from these biomarkers, that can help to decide if we should potentially add on a therapy or make adjustments to their amyloid therapies.